Hello, everyone. Thank you for being here, whether you're catching it live or watching the recording on a drive. My name is 𝗕𝗲𝗋𝗀𝗃. I am the head of sales here at OpenBots. We created a product that many of you know about, especially our client. It's called 𝗪𝗲𝗃𝗃 that focuses exclusively on the front end of the revenue cycle, especially on eligibility. Now, before we dive in, I wanted to introduce my co-host today, 𝗪𝗲𝗃𝗃𝗃. 𝗪𝗲, maybe you say some words?
Absolutely. Very nice to meet you. Very good morning to all our viewers today. Yeah, I'm very excited to have this discussion. My name is 𝗪𝗲𝗃𝗃𝗃. I'm the Director of Healthcare Automation at OpenBots. And like Gabriel said, we are really excited to talk to you about 𝗪𝗲𝗃𝗃𝗃, which is our product for insurance verification, and also talk in details about a topic which is really spoken in the world of healthcare, often overlooked, but it turns out to be very costly if you're not managing it, which is coordination of benefits. So yeah, I'm excited for this discussion, Gabriel, and I'm really looking forward to it.
Absolutely. So thank you for coming, 𝗪𝗲. So a quick note is that this webinar is built specifically for healthcare executives in finance, operations, and technologies. That means VPs of revenue cycle, CFOs, heads of operations. If you're basically working for a healthcare provider and are involved in either making money or saving money, you're in the right place. So I want to encourage everyone here to ask questions, be active, drop comments, share which location you're dialing in from. Excited for this. So now let's start with, why does coordination of benefits and denials actually matter? Now, at the end of the day, patients who legitimately need care are getting denied for reasons many times beyond their control, whether it's the wrong payer being billed first, hidden secondary coverage that was missed, Medicare Advantage plan switch and that nobody caught. It does hit the bottom line, but the reason we're all here is fundamentally it hits patient experience, and patients who need care are not getting it on time. That's the real cost of all of this. Now let's talk what's actually causing this. So in our world, for our clients, a lot of our clients originally came to us excited about wanting to automate things like prior authorization, right? Things that actually keep them up at night and kind of like what's hot right now. But then what we do is we always look at the denial report and say, well, what's really happening? And many times we find something kind of lurking underneath, and that really is what's called COB, or coordination of benefits, simply billing the wrong payer or the wrong primary payer. It's one of the biggest kind of silent killers across the rev cycle that starts in the front end, and you don't always find out until you submit the claim. That's the power of getting a COB denial, or one that used to actually rework, because by then the damage is basically done. So today, 𝗪𝗲 and I are going to walk you through, first of all, why this is happening, what it's actually costing you, and how we're actually fixing it with AI for a number of our clients. So let's start with the actual math. At a high level, the industry average is about 12% of claims get denied. Now, that specific rate is actually higher in specialties like dermatology, gastro, behavioral health. Any specialty care typically gets higher denial rates typically. That's a good kind of marker to figure out where you're at. And not to mention things like, federally qualified health centers, or FQHCs. They're extremely Medicare, Medicaid heavy, which starts the conversation on, well, they usually have multiple insurances. They can have a commercial and a government payer, which usually has to deal with actually leading to more and more COB denials. So out of all of those denied claims discussed, 1/4 of those denials trace directly back to manual errors within eligibility and registration on the front end. And within that, about half of all eligibility denials come directly from COB errors. Again, that's from having the payers in the wrong sequence, billing the wrong primary, or just missing a secondary payer that existed. So if you kind of break it out, about 1.5% of all net patient revenue, regardless of healthcare provider, is typically at risk every year. And also, it typically costs about $285, according to LTC, per denied claim to actually rework it or appeal it or figure out how to get that cash you did not get on time when you should have gotten it. So if you're a health system or health provider with 500 million in revenue, for example, that's basically $7.5 million at risk every year. If you're smaller than that, like $100 million healthcare provider in revenue, that's still about $1.5 million walking out the door every year if you don't actually address that. And then to compound that even further, you've all seen the stats and you're living this, is that about 65% of claims that are denied are never reworked. So it's a massive problem where so much money is being wasted on top of that patient experience being impacted negatively, that really you just need help with technology, because if you're trying to do it manually, there will be errors. There will be situations where you just can't get to it because you're just surviving or another fire came in that you have to actually address. So now let's get into actually per specialty, kind of what's happening. So we'll discuss a lot of these COB rules. We'll even do a little bit of a demo today with Ronald, but one of the biggest rules is actually what's called Medicaid as a payer of last resort. And that affects behavioral health and federally qualified health centers significantly. And the reason why is because a lot of them are pretty Medicaid heavy patient population. So staff might see a Medicaid card first, bill it out of habit, and then they might figure out, okay, why did I get a denial 60 days later? That's a painful part, because if Medicaid gets billed first on mistake, that denial can actually be bucketed as patient responsibility or written off entirely. Something was called the birthday rule. So the birthday rule is when a child is covered under both parents' plans, the parent whose birthday falls earlier in the calendar year has to be the primary. So with that simple rule, very easy to bill the incorrect payer. And specialties like ABA, so applied behavioral analysis, is a big specialty that gets hit by that, pediatric as well. And one more rule we'll discuss is Medicare Advantage always replaces original Medicare. That affects heavily skilled nursing, oncology, or cardiology, or any population with patients who are older in age. And the way that works is that basically if a patient enrolls in Medicare Advantage Part C, then the Medicare Advantage plan has to replace the original Medicaid entirely. So if you bill the Medicare, the wrong plan, if you bill the Medicare Advantage plan directly, like Humana, UHC, or Aetna, and not CMS, you basically get denied. So there are hundreds of rules like that exist, that it's very difficult to keep that just in the brains of your subject matter experts, and much easier to keep that in technology to do it automatically. So that flows very well into you, Ronald, in terms of, the industry says basically COB is easily done today, or it's not a big focus in that. But I wanted to ask you, Ronald, you tell us, like, why are denials still climbing here?
Great question. So that's actually a statement that we often hear, right? Like, hey, we have an EMR, and our group is using our EMR's eligibility module to run insurance check. But at the end of the day, we see that there are still denials that are happening even when the eligibility module of our EMR has run the insurance check and did tell us that this patient has insurance which is active. So if you try to think about this problem, there are two elements to it. The first element is what drives the RTE, real-time eligibility module, for the EMRs, or what drives the 271 response of vendors who are focusing on insurance verification. So the primitive factor that's going to be driving the entire process is what's captured by your front desk employee, the person who is sitting in the front desk, who is interacting with your patient or capturing the patient's insurance card. Now, if the patient walks into a clinic and lets you know about one insurance only, but in reality, the patient have two insurances, then the way RTE works is essentially going to take the same data which was fed by your front-end desk guy to the system. And that's the reason why you would see that even when your EMR is running the insurance check for all of your patients, and they are letting you know that 90% of the patients have active insurance, there would be a scenario that later on, after the encounter has been created and you submitted the claim to the insurance company, you get to see that some of those denials happened because the insurance plan wasn't verified and fixed in the front end. And that creates the confusion in the first place. That's one of the main reasons. I'll tell you the second big important thing. We often hear that EMRs have this eligibility module as part of their package, but the way it works is every single EMR is integrated with one specific clearinghouse or one specific gateway. Think about 𝗪𝗏𝗪 being one. Think about 𝗪𝗏𝗪 being one. And if I'm using an EMR and my gateway is 𝗪𝗏𝗃, then 𝗪𝗏𝗃 only covers, let's say, 50 to 100 of the health plans. What about the patients whose health plan is not covered within this 50 or 100? What happens to them? So the moment you run the insurance eligibility check for this category of patients, you will often see on the 271 response on the EMR, what comes as a response is a connectivity error, a content error, or specifically plan not found. But you still need to manually handle these particular examples. And at the end of the day, it's almost like you're handling 40% of the insurance verification manually by yourself. That's where we specifically see there's a big, big gap where if you have a solution that can mitigate this gap, I think healthcare providers would be a lot more relieved.
Well said. And to add to that, basically, if the transaction is automated, but the interpretation isn't, that's still a gap because anyone can automate, anyone can connect to portals. However, the biggest value here is using Agentic AI to actually read and interpret the eligibility response, usually called the 271 response. That's one of the biggest pieces of value because a lot of our clients say, hey, I can't just deal with surface level eligibility information. I needed the full picture of co-insurance, deductible, copay, in-network benefits, out-of-network benefits for each patient. And it gets very deep. And you get things with 𝗕𝗏𝗃𝗏 or within mental health and behavioral health, it gets deeper and deeper and more specific. And if for a person to handle that, it requires extreme expertise and requires a lot of time. So that's a big piece. So it's actually flowing really well in terms of the second biggest piece is that, I mean, Rano, a lot of times patients self-report the wrong insurance. So where do you go? I mean, I guess, Rano, how much of this comes from relying on patients to self-report their coverage, and what changes when you pull data directly from payers instead?
I think, yeah, that's a very interesting question. One of the questions which we often hear when we talk to the healthcare CIOs and the CFO specifically. So in reality, the insurance of the patients are coming from the patients themselves. The patients are walking into the clinics and they are revealing their insurance information. And that's kind of treated as the source of truth. But we all know that there could be 2 to 3 main reasons why the patient is not able to always speak out the right insurance coverage about them. There could be n number of instances, but let's take at least a couple. One of the most common use cases is a patient comes into the clinic and tells you that he has Medicare. But in reality, the patient perhaps have signed up for a Medicare Advantage plan, which is kind of run by companies like United Healthcare or Humana. Now, the hospital or the clinic in this particular instance knows that the patient has Medicare. The patient is getting the services from the hospital. When it comes to billing the insurance company after the encounter has been created, the hospitals would bill traditional Medicare. And the moment they bill traditional Medicare, they get an instant denial because traditional Medicare is not to be billed. It has to go to the Medicare Advantage plan, which could be United Healthcare, for example. That's kind of one of the main reasons why you shouldn't just rely on the patient for identifying whether the patient has one insurance or dual insurance or even as many as tertiary insurances. There could be other scenarios too. The more prevalent examples that we see every single day is the patient perhaps have left the earlier job or he has chased another job. But in the middle of this, he has always been going to the same provider group. And by mistake, he hasn't been able to update the provider that he has changed the job, which means his old insurance has been terminated. And right now, he is having a new insurance based on his new employer. Now, what happens when this particular patient is getting services and is getting billed to the insurance company? At this point, the hospital or the provider has no update whatsoever on what is the most updated insurance for this particular patient. So you either have to rely on communicating with the patient almost every single week, which is really not an easy thing to do for healthcare providers. But the other way out is depending on an agentic AI platform, which can constantly monitor and re-verify the insurance coverage of the patient throughout the patient's journey. So the point that I'm making is you shouldn't just rely on verifying the insurance of the patient once during intake and that's it. You should have some touch points, like you first try to verify the insurance during registration. You then try to verify the insurance of the patient maybe 24 or 48 hours before the date of service. And then you perhaps have to verify the insurance one more time after you created the encounter. The more you verify these insurances, the lesser risks you have and the lesser denials you will face when it comes to cascading the process downstream.
Yeah. No, I think 100% agree, man. You think you need a clear cadence of how often you're doing eligibility checks, whether it's a weekly check on all patients or bi-weekly or whatever it may be. Sometimes just doing more checks doesn't solve the problem, but the real fix is doing this COB automation, automatically interpreting the responses, and doing basically people can't do at scale. So maybe, Ronald, you can kind of get into an actual demo of how this works to answer a few more questions. But I think that the three things we'll cover is this. How can you actually read these responses almost like a senior biller would that's powered with AI with a limited time? Right. Number two, how do you actually check multiple payers at once, right? A single eligibility ping only tells you what one payer thinks. But if you have actual COB, like real coordination of benefits, you can't just rely on one specific payer. You need to actually confirm, you know, if Medicare is dormant or if it's a certain commercial payer that wasn't actually checked. And number three is figure out who pays first automatically. All of these rules that exist, they're rules-based things, and rules-based things means automation, right? Why would you only do and handle all those rules-based things manually with just people, especially with the amount of compliance, regulations, and revenue loss that can be attributed to it? So with that being said, Ronald, you can kind of break down how we can actually get it right at intake before the claim actually ever leaves the building.
Absolutely. And I think that kind of conveys why we built this platform in the first place, because you have to get more comprehensive information from these insurances so that you're just not relying on a single source of information and later on you're billing the wrong payer. So I think this could be a good way to let our audience know exactly what we have been doing. I think my screen is visible. People, can you confirm once?
Yep, it's visible.
Perfect. So for the viewers today, like, why does 𝗕𝗲 exist, and what's the main purpose for having an insurance verification platform, and what can you get from this insurance verification platform besides getting those active versus inactive coverage details? First things first, you always need to have a cadence in which you run the insurance eligibility check, and you can decide on the cadence. For now, as you can see, there's a dummy EMR that we have created, and we see that tomorrow, Friday, May 22nd, we have 3 patients who have an insurance or who have a date of appointment that is fixed for tomorrow, which is May 22nd. Now, the way our platform works, which is essentially going to be API first, it's going to integrate with your EMR, and it's going to fetch the list of all the patients who have an appointment in 3 days' time, 5 days' time, or 7 days' time. You can decide on that particular time frame. Now, this particular platform called 𝗕𝗲 is a platform which helps us to get all of these information from a 270, 271 response. First thing is to run a batch eligibility check. Now, you did see that on 22nd of May, all those 3 patients have their appointments. So the AI agents on our side is fetching the list of all the patients from your EMR, and it's going to run the eligibility for all of the 3 patients, as you're seeing on the screen, who have their date of appointment on May 22nd. And if you just see, I'll just scroll down a bit. The first thing that we are picking is whether the status says verified or not, which in this case, it is saying the patients have, all three of the patients actually have their eligibility status as verified. But more importantly, it's giving you the patient's financial responsibility related information as well. It's telling you the copay, it's telling you the co-insurance, it's also telling you the deductibles. At the same time, it's also letting you know some level of information about the coordination of benefits. Now, because all of these three patients had only one insurance each, the primary is selected as coordination of benefits, but I'll definitely take a deep dive on for specific patients who have multiple insurances and how does this platform determine which insurance should be the primary and which insurance should be the secondary. But that's the first thing. Now, this is a platform by virtue of these being a particular RCM platform. You can always use this platform to come and view the results. But what we have always done is to make sure that these patients' data is right now going to essentially flow back on the EMR itself. So the eligibility run for Francis John is right now fed into the EMR system itself. So you do not need someone from your team to just use this platform, see the responses, and manually key in the information on the EMR in terms of the eligibility responses, just as a note or maybe in specific fields within the EMR. That would be taken by us. That's a responsibility for our AI agents to take care of. Now, what happens next? You did run the insurance eligibility check, you saw the status, you saw the copay, you saw the deductibles. What's happening next is it is also going to give you some level of comprehensive information that you would expect a platform to give you. It would also be able to differentiate the commercial insurances and the government-related insurances and programs the patients might be enrolled in. In terms of services where you think you need a prior auth before the patient gets that service, in majority of the scenarios, the way we interpret a 271, we are able to bring this information whether prior auth is required for that specific service or not. This is what you are getting from a very high level, but this is not all of it. There are a lot of complexities which we would talk about. But first things first, capturing all the information in a comprehensive way from a 270, 271 response, interpreting the information in the right way. I think the word interpretation matters a lot to us because we are just not looking at 3 or 4 specific fields like whether the patient has active coverage, what are the coverage effective start date and end date, and that's it. We are also going into a multitude of other aspects. Things like whether the patient might have a secondary insurance, but that was not well informed by the patient in the first place. The way we read our 271 response, it actually denotes things like MSP, Medicare Secondary Plan. What does this mean? The 271 interpretation of this platform literally tells you that Medicare is exclusively not primary, and it denotes it by a word called MSP. But it also tells you who is the primary insurer, what is the policy number, what is the coverage start date and end date of the primary insurer, and the MSP reason code as well. So we are trying to make sure that this platform is not just returning you eligibility responses, but it is also letting you know about those secondary or tertiary insurances of a patient which you couldn't capture during the patient intake process. Now, let me take you to Cardio once again, because the real coordination of benefits magic would happen within our eligibility platform. Now, this is the list of all the patients for whom we have run the insurance eligibility check. As you can see, that there are time-stamped information along with the patient financial responsibilities. If I take a specific example of Brian Williams, The reason I'm taking this example is because Brand Williams is having, as you can see, Blue Cross Community, it is having as primary, it is having another secondary, it is also having Gold Plus integrated as tertiary, and Florida Blue Medicaid as the fourth insurance. So this patient literally has 4 different insurances. Now, this is where the complexity starts. This is where maybe someone in your team, while verifying the insurance, did verify the active insurance information for all of these 4 plans. But maybe due to some mistake, while ordering the insurances, the front-end person might have done some error. Like Gabriel was saying, all of this information, it's tough to keep all of the NAIC rules for coordination of benefits mapped out in your brain, because there are thousands of rules and the rules are constantly increasing with days. Now, let's say by virtue of an administrative mistake, your front-end team member have tried to fixate Florida Medicaid as primary and have saved this particular order. What happens when you are going to bill this particular claim in relation to these insurance companies? This is the order that we see currently. Now, our platform by default is always going to run a COB request for all of the patients who have dual or more insurances. Now, if I verify the coordination of benefits feature in this particular platform, you immediately get to see that Blue Cross Community once again becomes primary. Florida Medicaid becomes the last payer in the list. Now, why did this order reshuffle? It did not reshuffle all of a sudden. The system kind of tells you the determination methods for this particular order. It first tells you that if you have multiple insurances and mostly they are commercial, then Medicaid is always the payer of last resort. It also tells you, like, how did it determine out of the 2 commercial insurances, which one is primary? It kind of tells you, like, both the insurances are active, but the one commercial that has been in effect for the longest period becomes the one which should be billed as primary. Now, there are hundreds of rules like this, but this is one example where you get to see that even if you have run the insurance of every single patient, but while creating the encounter, you have perhaps not looked at all the rules that you should apply when the claim goes out of the door to the insurance companies. This is a preventive feature which can prevent the denials from happening in the first place.
Yeah, and it seems like because there's just the amount of triggers that can cause these errors. For example, we talked about wrong primary and secondary order on the claim. We talked about missed secondary or other active coverage, but also it could be an outdated COB, which is the reason why you want to do it as often as possible and recheck COB when you do now eligibility check, not to do a soft check, but actually a hard VOB, verification of benefits, as often as you can. Or what if the claim was submitted to secondary before the primary EOB came back? That can also cause an error right there, and so you might go into a denial. Or lastly, and a big piece is just if a patient self-reports incorrectly. So you shouldn't just rely on what the patient says, because you should actually rely directly on what payers are saying. That's the most reliable approach there.
Absolutely. And one more important thing is there's always, like, there's a scramble for healthcare face ladies when we talk about things like, hey, how often do you run the eligibility check? And do you run the eligibility check 24 hours before the date of visit, or you run it 72 hours before the date of visit? Yeah, that is a very interesting thing. We often notice it's mostly between 3 to 5 days before the date of visit. But you do have the control, right? I mean, you can always feel like, hey, 3 days is not enough. Tomorrow I need to kind of make that 5 days in advance. But in reality, you are seeing hundreds of patients every single day. It's not so easy for a team of 3 dedicated insurance eligibility folks to run the insurance check of hundreds of patients every single day. So here's one thing that we have constantly focused on, which is making eligibility insurance run as part of your wish list, and the wish list could be determined by a particular event-based trigger, or it could be determined by maybe the day gap, like you want to run it 3 days in advance of the date of service. And we have a rule in this particular platform. This particular rule allows you to run the insurance check of the patient, not just once when perhaps the insurance was added and updated in the EMR, or not just maybe 2 times after you have updated the appointment. You can run as many as 7 to 8 times all throughout the patient's journey. There are ample amount of situations that we have faced when one of our clients who have just enrolled their patients on the EMR today, but the patient might have a date of service which is 4 months out from today's date. And it could very well happen for a multitude of reasons that the patient's insurance has changed in this 4 months before he walks into the clinic one more time for the date of service date. What happens then? You can absolutely update this particular rule and let this platform know that I'm going to run the insurance check 2 days before the date of service and one more time when the encounter has been completed, so that you do not have that margin of error to miss out on the right insurance coverage. So you should always be keeping yourself updated with what the patient's insurance is and whether that is up to date as of today. The other thing which is very important here, which we call as a scheduled event, which simply means for all the upcoming appointments that you have on your EMR, do you want to run the insurance check 7 days before the date of service arrives? Or do you want to run it 3 days ahead of the date of service arrives? You have the control. It's just a matter of it's just a matter of time. You fixing this particular time period. And what happens later on is our platform that is already integrated with your EHR is going to look for this particular information. It's going to fetch the record of the patients 3 days ahead of their date of service and run the eligibility check accordingly. This is from a very high level what we kind of automate. It's not just about looking at a 271 response and letting you know which patients are active versus which patients are not, but it's also the fact that we rely on comprehensive data. As we speak, this platform is integrated with 2,500 payers, including the major gateways like the Validity, Waystar, Navinet, United Healthcare, and the state-specific Medicaid plans. But finally, one thing which I think I should touch on a little bit is our Eligibility Intelligence Center. Denials are preventable in 90% of the cases, but think about a real-time scenario where you did have a denial that stemmed from insurance eligibility. And you being a CFO, you don't want to make the same mistake of currently having the same pattern get repeated for eligibility-related denials. What this platform is eventually going to do, it's going to let you know that for all the denials that stemmed from insurance eligibility, which are those that were related to coordination of benefits, where you have billed the wrong payer in the first place, which are those where you didn't even find the member in the first place, and which are those where you have an inactive coverage. So it clearly gives you the insights and the analysis that you need to take so that you're not repeating the mistake over and over again.
No, absolutely. I think well said. I think that the point you're making is that for a team to actually balance payer rules or diagnosis specific rule sets or patient documentation and the endless amount of payer portals today that are needed to retrieve accurate information for each patient, it's not easy. And if you're ultimately handling verification manually or solely with your out-of-the-box EHR functionality or off-the-shelf tools, it will inevitably lead to errors. And the key piece here is basically being able to actually automate the reading of these eligibility responses with technology that has all of these COB rules set up and all this automation within it. And the reason why I want to ask you a question in a second is because there's typically 2 approaches when folks are managing eligibility manually. Approach number 1 is basically a decentralized approach. This is the most common, and where there's basically a handful of intake staff at each location that kind of handle eligibility, verification, COB on a part-time basis. And it actually leads to the most errors because no one truly owns the process. It's kind of just done part-time when you have time, as patients come in or before the patient comes in. Approach number 2, which is better, but still very automatable, is basically when there's one dedicated team fully responsible for insurance verification. It is a better approach, yet it's still riddled with a lot of manual errors because it's manually being done. But the point here basically that you were making is that you can actually have all this automated regardless of your approach, especially things like having the patient financial responsibility automated, getting the co-insurance and the co-pay and the deductible, right? Because you can actually benefit from things like calculating the patient estimate ahead of time by having that out-of-pocket exposure before the patient comes in, and you actually collect before the patient comes in, which makes things smoother for the patient, for the provider, and for everyone involved in the process. Or things like coverage termination detection. If a coverage is terminated, or maybe it wasn't terminated for your first few visits of whatever service you were getting, but it was for visits 4 through 6, for example. So that's something that you actually can ahead of time catch to make it easier for the patient provider. And even grace periods. Like if you're a patient who stopped paying your premium, that can be caught actually, because automatically if you check that on a payer portal, it might show up as active, as green on the payer portals, but you need to look deeper into the actual 271 response, which you can do with technology to do that. So when you solve all those problems on top of the COB piece, on top of getting all of the benefit intelligence for the limits, the out-of-network, the deductibles, and being able to actually integrate with all of the portals and right back into your EHR, that's how you actually have a fully automated eligibility process with as minimal people involved as possible, so you can focus on patient care. That's kind of what's happening with the most elite healthcare providers today, rather than saying, you know what, I have some eligibility tools and I have a bloated team doing it, but I'm okay. That's not the best approach, because eligibility verification is the most voluminous transaction within healthcare, and therefore the one most prone to errors that end up leading to denials or rework on the back end. So the question for you, Rano, obviously this is a big piece of your wheelhouse, and on everything you showed, I'm curious, what happens if AI isn't sure? Like, how do you handle exceptions, and where is the moment where human judgment still matters? Because you can't just say, hey, we don't need people anymore. You do. There's nothing more powerful than expertise, especially healthcare revenue cycle management expertise, to get things done in the right way. So, I mean, tell us a little more about how that works.
Absolutely. One of the things that we often have to realize is AI is not perfect. AI has gone to a point where it can definitely accelerate the process. It can definitely be used to do subjective thinking. But at the same time, there are a few things which, I mean, at least as of today, humans are better at. Now, things like, let's say, the coverage of a patient, it's not properly captured from a 271. There could be situations like this. What happens then? We do have a confidence scoring place in our system where it tells you literally whether the AI has captured the information in the right way or not, and if it has captured the information, how confident our AI is. At the same time, if it is not confident or it hasn't captured the information in a proper, comprehensive way, that's where that part of the workflow would literally stem into a human queue, where someone from the provider office is going to take care of that particular information. The other thing which we often hear, particularly in the world of autism and ABA, is there are specific service codes for which you won't find the service level benefits always available on the portals. Regardless of whether you are integrated with 2,000 plus payers, you will never find those information of those specific service codes in a portal. And you need to call that insurance company to understand exactly what the copay looks like, what the deductible looks like, what are the coverage information. And as of today, it's still more prevalent for humans to do that as we speak. And I'll tell you the reason why. It was one of our customers who told us, this week that organizations like Cigna, when they are detecting a phone call that comes from a voice bot, they are immediately trying to decline that call. So it's not that the providers are just using AI, the insurance companies are using AI too to kind of like maximize their benefits. But when you're not finding any specific information for some specific service codes, you need to rely on humans to take care of those edge cases. So I would say these are the two areas, Gabriel, where we often see that you still need to rely on human, and think about the exceptional cases where AI is not confident about the coverage information it has extracted from a 271. So it is going to transfer that part of the responsibility to a human to handle it for the end.
So well said. And I think another thing that matters is what have been the results in the industry. So I'll tell you a quick story of one of our clients. So one of our clients is one of the largest behavioral health, nonprofit behavioral health organizations in the country. And originally they came to us really wanting to automate eligibility, same story as everyone else. When we dug in, the real problem was COB, right? They had a lot of guarantors that were constantly in the wrong order, and it took a lot of time manually to put them in the right order. So what we did basically was, because we're connected with over 2,900 payers, you can read the responses and solve COB. We didn't just kind of ping the payer and hand the response. It's not what we did. What we did was we actually went deep in terms of automating every single piece of the manual step across the sizable team. And they had a team of basically 8 folks. And that team of 8 folks, based on all the work they were doing, dropped down to only one person, basically managing the automation for about 2 hours a day, about 1/4 of their time. And it freed up those other 7 folks to do a lot of work that needed to be done that was not being done because they did not have the time to do it. Additionally, they actually ended up having about 400-ish denials monthly. That dropped to 50 denials monthly because those were coming primarily from a lot of those COB errors from the wrong payer being built or the wrong guarantor being built. And lastly, their AR had a really massive impact because of this, because a lot of those eligibility denials were kind of going downstream into the back end and bloating their AR and making it so that there was a team able to follow up on much more than they needed to. So it was a pretty massive impact. And the last change is basically taking about 1 minute manually to actually put every single guarantor in the right order. And when a bot was able to do it in about 5 to 10 seconds every time. So by the time one person did one, the bot had basically done 6 or 7 of them. That's the power of automation on top of the level of accuracy that was able to have because of that. So I think as we wrap this up, I think if you're a healthcare provider where you're intrigued in this, I mean, number one is one of the single most useful things you can do is, first of all, look at like your last, your top 100 denials from the last 3 months, sort by the reason code and count up how many of them are actually related to eligibility or coordination of benefits are coming from the front end. So for example, CO22 is one of the most common, basically insurance's primary denial codes that exists on top of MA01, MA02. Those are also related to them. So start looking at those because you'll usually find that there's a very big chunk of them. And basically every second that you wait is more manual time wasted, more money you're losing. So I think what we'll do too is we'll actually drop a calendar link in the chat for everyone that's here. And on top of it, you can kind of skip the form and go straight to a calendar if you actually want to talk to us a little bit more about this and actually analyze what your situation is and see how relevant automation can be to you. So anyone who joined this webinar will also receive a full summary of what happened along with the recording. And I think we have one question I did want to ask you, Rano, in terms of the Q&A. So based on that story, the question is, how did this work? Like, how does this specific technology work for behavioral health in particular, if you don't mind me asking?
Yeah, absolutely. So this technology is going to work across all kinds of specialties, but we definitely do some fine tuning depending on which specialty we work with. I'll give you an example of one of the largest clients we have and one of the largest mental health care providers, non-profit mental health care providers in the States. So this group was based out of Missouri. They're a mental health care based group. And the main problem was actually coordination of benefits. So they had to really work on a lot of denials where the denial stemmed from the point where they were billing the wrong payer in the first place. Now, before implementing this particular product and baking that into part of their workflow, what we figured out is insurance verification is one thing which we can definitely do. But more importantly, the problem they had could be called as a service line based guarantor ordering. I'll give you an example. Think about a patient who walks into any of their clinic and renders the service of SUD, substance use disorder treatment. And that patient might have two insurances. One is a Medicaid MCO, and the other is a commercial insurance. Now, the way this particular healthcare provider used to operate is for SUD, they would always bill Medicaid MCO because that's part of the carve-out of the Medicaid MCO. They would never bill a commercial insurance like BCBS, regardless of whether the patient had BCBS on top of their insurance stack. So what our platform did is to first run the insurance check for patients who had a dual insurance or patients who had three insurances at the same time. But depending on what specific service the patient has been rendered, it used to work from a ranking order where it can figure out which payer it needs to bill for that particular service, which could be SUD, which could be psychiatric counseling, which could be detox program. And it arranged the insurances in the right way on the encounter level as the encounter later on converts to a claim which goes along to the insurance company. We had massive results out there. I think when we started the discussion with them, they were landing with 1,000 denials a week, which later on replaced to 50 denials a week. It was a team of 8 people whose activity was mainly to kind of figure out where have we missed out the mark and we built the wrong insurance company and what the fix looks like. And I think we have been working with this group, we have seen massive results, and we want to make sure that we can propagate the same thing to the other healthcare providers who would like to kind of streamline the revenue cycle process.
And 2 more questions I'll run through real quick. I don't know, I can answer these actually. So we tried automation before and got burned. What's different about Agentic AI or this approach? So I think with traditional like task automation or robotic process automation, it was very task oriented. It was very, hey, this is a specific rule. Like if this, then this, that can work, that can help some things. But when you have a plethora of rules and you have to actually interpret a lot of unstructured, messy data from disparate sources, you kind of need something a little more powerful to do that, especially not just Agentic AI, that's generic, but actually one designed with healthcare subject matter expertise in mind. That's the only way to really do this that can, in a way that can actually add value and address the root cause of issues. Number 2, does this work on EHRs like Athena, Cerner, Epic, Next? Yeah, absolutely. So any of the largest EHRs, usually the benefit is that they actually have really good APIs. So things like Fire APIs actually preferred for us instead of 807. So that's kind of the way that it approaches. But a lot of these EHRs also have out-of-the-box eligibility tools with help. But the issue with that is that it helps usually work for soft checks or getting a slight picture that can help for some of the clean checks. But for the checks that actually have a little more complexity to them, and usually it could be like 50 to 60% of checks, that's you need something that's a little more horsepower, like an OpenBots Cordio of that nature. So as we wrap up, just to kind of recap what Ronald discussed and what I discussed, I mean, today what's happening is that there's a 12% eligibility, 12% denial rate in the industry claims. Basically 1/4 of that's eligibility, and then half of that 1/4 is basically coordination of benefits. And to make matters worse, 65% of denials are never reworked according to CAQH. So the question is, how do you fix this? So it's not just manually doing more eligibility checks. The real fix is really doing that COB automation to automatically correct payer orders at the onset and not just kind of wait until when the claim is submitted and getting back to us at that time. That's not the best approach. And being able to actually read a 271 like a senior biller, but with technology, checking multiple payers at once and automatically being able to incorporate all those rules, like the birthday rule, the Medicaid as a last payer rule, right? All those rules that end up kind of leading to denials later on. So very excited to kind of keep going and keep pushing with our clients, get it right for the first time at intake instead of waiting until the claim leaves. Thank you very much for your time, Ronald. And if you all want to learn more, go to 𝗪𝗲𝗃𝗍𝗪.com.